Hello and welcome to lesson 6. This lesson, we're going to talk about contrast media and techniques. So I'm just going to go ahead and give you some really good pointers on contrast media. I'm not going to go heavily into that because I do have a separate course that focuses just solely on contrast media. So make sure you go check that out if you're interested in diving more into contrast media. I'm going to give you some really general points in here because this is a crash course on the CT Blueprint for you new and upcoming wonderful technologists. All right, so let's go ahead and get into it. So we're going to talk about understanding contrast media, okay? So contrast media, we know, is used to highlight the organs, the different structures, pathology on a CT image. So I can just roughly say about 90 to 95% of the CT exams that get ordered, 9 times out of 10, they're going to order it with contrast. So there are several ways that we can use contrast in CT. We use oral, IV, and rectal contrast for administration, okay? So I'm going to just talk about all three of them if you're not really familiar, or this might be a little bit of a refresher. So oral contrast media, which is typically what we use, this is where patients drink to visualize the intestines. It could be in several forms. So it could be ReadyCat, gastrographin if your facility still uses it. I know a lot of facilities have phased out gastrographin. I know currently in my facility we use it. I'm not sure why, but we don't make those decisions. So, or oral Omnipaque. Now, Omnipaque has been approved by the FDA for oral consumption. So we do use it as IV and oral. Whether it's 300, 350, really doesn't make a difference. We do use 350 for oral consumption at my facility and for rectal contrast as well, and for cystograms. I know at another facility prior, we used 350. I know others, they use 300. It just depends on your protocol. Now, Brisa is what we use as well for enterography studies, and I know MRI uses Brisa as well. We used to use Volumen, but Volumen was phased out, so Brisa is the method of choice now. Now, we also do IV contrast. So usually oral and IV contrast go hand in hand, unless it's, the emergency room. Usually we just do IV only, unless there's a specific reason on why the ordering ER doctor wants oral contrast and to, use that on their patients. So of course it's injected into a vein. We visualize arteries, veins, different types of organ structures like the liver, kidneys, pancreas, things that we can see. Omnipaque 350 or ICView 370. I know a lot of places will use 300, which is perfectly okay. But typically, this is what I've seen at most facilities that I work at. So these are just some general things. Okay, so make sure you check your protocol books, check with your policies on what you guys use. And then, of course, rectal contrast. So rectal contrast, I know at my level 1 trauma center, we use it for trauma protocols, or you use it for some kind of, sigmoid fistula, colorectal fistula on women if they're trying to see if there's a fistula in the vaginal canal. We use rectal contrast for those purposes and either other diagnoses as well. So I know at my facility, we use gastrographin. Most facilities, they'll use Omnipaque 350 or 300, whatever it is, ICView 370. So it just depends on what your facility and your protocol is. So that's basically just kind of a general, understanding of it. Now, power injectors, okay? So in CT, we use a bolus injection method. So we use power injector to push contrast through the bloodstream, okay? Because if you've ever tried to hand push contrast, your hand is probably going to hurt a whole lot, okay? So it's because contrast is very thick and it's like shoving a bunch of maple syrup into somebody's vein. So I know I had a pediatric physician that it was just on a baby and we were only injecting like 10 cc's. And even him saying it was really hard to push, like he cracked that syringe. And him and then the ICU nurses that were with this baby that we were doing this cardiac scan on, they said, now we understand why you guys request the IVs that you do. So it was a very positive learning experience considering we went back and forth with them when they physically saw how hard it is to push it and why we asked what we asked for because we need to power inject it. They understand why. Now they don't give us a hassle anymore. So there's two types of power injectors, okay? There's like a single and a dual head injector where the dual head injector uses contrast and saline. Now, I know that Some facilities may still have a single. I know I worked on a single when I first started CT many, many years ago, but I know they've since been phased out because dual injectors are the way. So the dual head injectors, are the standard. So some facilities I know will still have a single, and there's nothing wrong with that. But I know that MedRad has really just kind of phased those out, and you don't really see too many of them anymore. So this is a picture of the dual head injector, of course. So this is a MedRad Stellent. Ever since this picture, our facility did upgrade to the Stellent Flex. I'm kind of like, I don't know, the jury's out for me on that one because the Flexes, we've been having some issues with it. So we use saline in contrast. And what I always strongly recommend is to do a chest injection to check for IV patency. So between 20 and 30 mLs of saline before you give that contrast injection, okay? Some places use 50. It just really all depends. I know I'm used to using 20 cc's before I do any contrast enhancement, just to make sure that, we inject at the same flow rate as contrast, just to make sure that the IV is going to be good for contrast injection. It's just a safety precaution. Sometimes the test injection will be good, and then all of a sudden the contrast doesn't go as planned. You deal with that case by case because that sometimes does happen. Now, what I stress very importantly when I train anybody, and you as a new technologist, this is very important. Priming your tubing. So this is proper elimination of any air in your connecting tubing to prevent an air embolus. And yes, air embolisms, unfortunately, are more common than you think. So what I always strongly recommend is after you drop your contrast, put on your tubing before you connect it to the patient, make sure you prime that tubing, that there's nothing but either saline or contrast going through there. Make sure you do that before you hook it up, okay? Because you are the last check to make sure before you start that injection, okay? Now, we prefer certain IV access in CT. So typically, because contrast is very viscous and a lot of times we're injecting at a very high rate for angiography studies, different types of imaging such as a PE or dissection studies, 18 to 20 in the AC is preferred in CT. Okay, so an 18 is green, 20 is pink. Now in CT, if it's not for a CTA, it's just a routine CT. A 22, 24 gauge can be used. Now, 24 gauges, we use those for pediatrics, okay? They can be used under special circumstances. It really depends. But usually 24 gauges are reserved for pediatric patients. And usually for pediatric patients under the age of 5, you can get away with doing a hand injection, okay? So there's also a 22 diffusix that can be used for CTAs, okay? So it's blue, but on the hub, it's purple, and it tells you how fast and the PSI you can inject in. So usually diffusix, you can inject up to like a 6.5 with a 325 PSI. And usually diffusix are used for patients who are a really hard stick. Now, diffusix actually comes in all gauges, so 18, 20, 22, and 24. We use the 24 gauges for like pediatric hearts because we can power inject through them, and usually we need to. Okay, so those are the types of IVs that you can use. I wouldn't recommend using a 24 gauge on an adult or contrast media unless you absolutely have to. If it's for like an abdomen and pelvis or something like that, make sure you talk to the radiologist, and see if it's doable, okay? Now, we also have power lines. So like a power pick line, they're purple. They can be used for CT, and it tells you on the hub, you can inject to like 5 mLs per second. Okay, so make sure if you get like a pick line from another facility, make sure you verify it and that it's power injectable. Okay, I know all the ones that we put in our facility, they're all power injectable, and even the sister hospitals around us. And then a lot of times with chemo patients, they have power ports. So these can be used in CT. So a lot of times, how do you know if the power port's injectable? They look like a triangle and it says CT right in the middle of it. Or they're circular and they'll say CT on the middle of it on a chest x-ray. A lot of times when they're accessed, the hub will tell you itself it can be injected at 5 mLs per second. If you don't see any of those things, do not use it. Do not use it, okay? Because it's probably not power injectable, okay? Make sure that you look in the chart, ask, get documentation that we can use that line. Now, we also have power central lines, okay? These are very common. So these are power central lines that have come out. So it's 3 hubs. Usually it's like a blue, a white, and a brown. They can be used in CT, and on the hubs, it tells you the flow rate, okay? So these are, they have been tested by MedRAD, and we can go ahead and use these 3 types of access. Now, I'm going to stress this very importantly because I know I go back and forth with nurses every single day. When it comes to a Swans, a Hickman, a Cordis, or even a Broviac on a baby, okay, these are sheaths. These lines are not power injectable and cannot be used for contrast. Please do not do this because these are used in trauma protocols, cardiac patients. These are not power rated by MedRAD. Okay. And even we had a big debate at my hospital where we actually called the rep, and the rep sent us a voicemail back and said, absolutely not. They're only rated for a 45 PSI. We know you guys inject at 300 or more. Please do not use this line for contrast injection because it has not been tested. It has not gone through the proper channels. You cannot use this. So please do not, because they are not power rated and you cannot use them at all, okay? You can get in a lot of trouble, and I've seen a case where somebody used a Cordis, completely cracked the tubing, and the patient had to immediately go to the OR because they had a clot and it was just a hot mess. Do not use these lines. If they pressure you to do it, no. You can call the reps, get the literature, even out of the packaging, it'll tell you exactly, because these are things that they slam a bunch of fluids and slam things, but that's hand pushing. Power injecting at a very strong force. We're talking about 300 PSI, that's pounds per square inch. So do not use these. All right, so flow rates. So your AC lines typically, depending if it's an 18 or a 20, 18s, we can actually power inject a little bit higher. So typically it's between 4 to 6 mLs. The only time we would ever inject at 6 mLs if we're doing a cardiac study and the patient's like, close to 500 pounds, okay? Or even a PE study, as long as they have a good 18, that's good, you can do it, okay? Lots of techs get nervous. I know I do, but sometimes, you have to get an optimal study if you can, but cardiac output, is very important in those cases. Now, typically, times lots of patients don't have ACs, and they'll have like a forearm that's like below the AC. Usually, you can get away with like 3 to 4 mLs if it's really good. Okay. Sometimes if we're doing like an abdomen pelvis, neck with contrast, a head with contrast, and they only have a wrist or a hand, you can get away with 1.5 to 2. I always tell my techs, use your best judgment. Whatever you flush it at will determine how fast or slow you're going to inject. Okay. And then with pediatric patients, this is my recommendation, but whatever your facility's policy is, please follow it. Pediatric patients, I always recommend everybody to hand inject if it's anybody under 5, with the exception of pediatric cardiacs, because we'll let the cardiologist dictate on what they want as far as that, okay? If we can get the 24 gauge diffuse 6, we'll inject it. If not, usually the peds cardiologist will say, no, here, the doctor's going to come down if they're really unstable, and we're just going to hand them the contrast for them to inject the line. Okay, so I always strongly recommend do a hand injection because we do 1 cc per pound. So if the patient weighs, 10 pounds, 10 cc's of contrast. Okay, so that's my strong recommendation. Okay, I don't really recommend power injecting any kids under 5 because it can be dangerous. Now, we typically use like a 1.0 per second power injection rate for peds. Anybody that's over the age of 5. Sometimes you can get away with just 1.5. I always tell everybody, use your best judgment. Use your best judgment, okay? Because pediatric patients have smaller veins. We have to be very careful. In hand injecting it, you can just hand inject it, let it all go in, and then hit the button. It's going to be a perfect study, okay? But always follow what your department policy is. These are just some standard things, okay? Now, contrast reactions and emergency protocols. So very often we get patients who are allergic to contrast because they've had a prior reaction from a prior test, or they've had a reaction after we've given them contrast, or I've seen patients get become allergic to contrast because they have a long list of allergies, which puts them in a high category of that. Okay, so it's important to screen all patients for allergies and make sure you verify all their allergies in their chart, and even talk to the patients about allergies, because sometimes they'll tell you allergies that aren't in the chart. So make sure you communicate with your patients as far as that, if you're able to, or from family, or just verifying from the chart if they're intubated. Now, signs of contrast reaction, the patient will get itchy, they'll start to swell, look like Stay Puft the Marshmallow Man, they'll get hives, they get short of breath, difficulty breathing, tightness in the throat, tightness in the chest. So make sure you know how to what's it called? Sorry, recognize the signs of contrast reaction. So, and in the event of that, you have your rapid response team, you have your reaction box, things like that. And then your pre-medication protocols that can be used at the discretion of the ordering physician or whatever your radiologist would like you to do. Typically, we do a 13-hour prep. That is what's highly recommended, okay? Unless, the patient's in the ER, then a 4 to 6 hour prep can be used. If you deviate from any one of those, I would get your radiologist involved and have them talk to the ordering physician, okay? Because we have to be extremely careful, especially if patients have anaphylaxis. Okay, so that is the end of lesson 6. Lots of information there, so hope that it's really, really helpful. Now, in lesson 7, we're going to go over some basics of CT anatomy and pathology. So I will see you in lesson 7.